This conference will now be recorded.
Whatever you did, it worked. It turned on.
Yeah, it did. Okay. All right. So I'm going to just welcome everybody quickly, and we'll go down the list momentarily. But a couple of announcements, if you like, up front that are very exciting and rewarding for me. The first is that I just had lunch with Alan Adele, and some of you know him as Tall Alan from the Healing Well and the Health Unlock community. And he has kindly agreed to serve on our advisory board, which I am really thrilled about. I've known I'm sorry?
I said fantastic.
Yeah. So we've known Alan for a while. In my view, there are a few patient advocates, particularly for prostate cancer, in this country who are as knowledgeable as he is when it comes to issues around radiation. So we've always asked him in the past and sent people to him if we had questions, and he's always been very receptive. But I feel easier about doing that now since he's agreed to serve on our advisory board. So that's good news for us. The second thing I just wanted to mention is that we are looking forward to some good plenary sessions as the fifth Mondays crop up. Whether we'll be able to use them this year, I'm not sure, but certainly for 2019. Two of the people that have agreed to do plenary sessions with us are Peter Kafka's doc, Jeffrey Turner, who gave a very good session on immunotherapy and is more than happy to deliver that session to us sometime next year. And he keeps it updated, so anything that changes will be included. And then Fabio Almeida, who most of you know, has he's recognized as being a nuclear medicine, as having a nuclear medicine specialty, and has done a lot of imaging with that, and a lot of people have chosen to go to him for imaging. However, moving forward, he has now added to his internal medicine qualification and his nuclear medicine qualification. He's become an integrative oncologist, and he's very big on diet and exercise. He's lost an enormous amount of weight and looks terrific. And he'll do an integrative oncology medicine session for us to talk about diet and exercise and everything else sometime in the next few months. So really, really happy that we've made these connections. I'm going to do it rather than going straight to David Bowles about his situation. I've asked Len if he could just give us a 10-minute upfront summary of what he found to be the most interesting revelations, if you like, at PCRI, which he has kindly agreed to do. Len attended more sessions than any of us, actually probably any of us all put together. And so he is the man to tell us what he learned. And maybe we'll just have a quick 5-minute, but not a long question session after that. And then we'll go into the regular meeting where we'll let David tell us a little bit about his situation, and we'll catch up with everybody. So the microphone is yours, Len.
Okay, thanks, Rick. Of course, it's impossible to summarize 3 days of conference lectures in 10 minutes. So what I'm going to do is just quickly read through what I have, but I'll send an electronic copy of this to Dave and Rick, and you can either post it on the website, or Rick, you can just include it as an attachment in an email to Wrestling Papers. Attach it to an email to everyone.
Okay.
And on top of that, I will be getting a DVD. I don't know if anyone else who went, Rick, is also receiving a DVD, but I'll be making that available to any members of Answer Cancer. All right, so we'll start with Dr. Gerald Andrioli, Chief of Urologic Surgery at Washington University in St. Louis. There are two of them. His advice to all men: get the first PSA test at age 40 and again at age 45. If it's between 1 and 1.5, see a urologist to monitor PSA. That apparently is concerning to him. At age 50, if your PSA is less than 1.5, you will not die of prostate cancer. Seems like a bold claim, but that's what he said. Do not get the standard blind 12-core biopsy. It's a coin toss. Picks up only 50% of positive cases. So it's, in his words, useless. Instead, get an NP MRI PET scan with fusion ultrasound for targeted biopsy cores. He believes biopsy needles should not be inserted rectally. Too many infections. Instead, have perineal needle insertion, much safer. Dr. Evan Yu, professor of the Department of Medical Oncology at the other University of Washington in Seattle, he authored a paper titled Targeting Intramural Androgens, Statins and Beyond. He claims that statins can inhibit cell entry of Zytiga and Xtandi along with cholesterol, which is their intended and desirable effect. I asked Dr. Jeff Turner what he thought of this claim by Evan Yu, and Turner said the evidence is weak and this should not be a reason not to take a statin. Who's right? Nobody knows. Like so many things in prostate cancer treatment. Let's see. Dr. Evan Yu also said Keytruda, pembrolizumab, is effective in patients expressing PD-L1 marker. That was already widely known. He says Provenge works best in patients with metastatic castrate-resistant prostate cancer when the PSA is less than 22. The hazard ratio is 0.51. But he says it continues to work across the full spectrum of PSA values. So, for example, even with a PSA greater than 134, hazard ratio is 0.81, which is still better than, let's say, non-treatment, which would be 1.0. As a counterpoint, Dr. Eugene Kwan of the Mayo Clinic, in his lecture, said he wouldn't give Provenge to his dog. Again, these are the experts completely disagreeing. So Dr. Evan Yu again says Xofigo works better if given before chemotherapy. However, if a patient has bone pain, then he'll give Xofigo first. Dr. Mac Roach, professor of radiation oncology at UCSF, this is Rick's former doctor, says his data show that ADT should be given for 4 months along with radiation therapy for intermediate risk patients and for 28 months for high risk patients, which is exactly what Rick took. He admits that testosterone levels in older patients may not recover well after 28 months of ADT, but the survival benefit is there. He briefly went over new forms of radiation not yet available, including something called microbeam radiotherapy, flash radiotherapy, where 4 grays per minute are delivered. This is incredibly intense. He says this minimizes the effects of patient movement during radiation and should therefore result in less collateral toxicity. All right, getting back now to Dr. Eugene Kwan, Mayo Clinic. Prostate cancer is a heterogeneous, genetically unstable disease. Imaging is not just everything, it is the only thing. There are over 60 different types of prostate cancer at the molecular level. Here is a quick summary of Kwan's The Good, the Bad, and the Ugly, borrowing from the Clint Eastwood movie. The good, adeno or adenocarcinoma, pick your pronunciation. This is the typical prostate cancer. Produces ESA, it produces PSMA, and it responds to ADT and taxane chemotherapies. The bad, neuroendocrine cancer, androgen receptor negative, synaptophysin positive, responds to platinum-based chemotherapies. I'm halfway there, Rick. Am I going too slow, or is that all right?
Keep going, keep going.
Okay.
5 more minutes.
Okay, that's the good and the bad. And the ugly is small cell cancer. Absolutely no markers. Responds to platinum-based therapies. Needless to say, those are very aggressive types of prostate cancer. Okay, I'm still summarizing Kwan's lecture. Vaccines do not work in cancers of any kind. They initiate immune responses, but they are not sustained. I don't know how many guys here have heard of CAR T therapy. This is the latest and greatest. Stands for chimeric antigen receptor T cell, CAR T. Kwan says it may not work for prostate cancer because prostate cancer is too heterogeneous. CAR T therapy works best with clonal cancers. It's already been approved for certain leukemias and lymphomas, which are all clonal cancers, meaning there's one cell type, and that one cell type is proliferating, creating the cancer. They're kind of like identical cells. So if you can just target that one cell, you'll get them all. Okay. Kwan mentioned this because apparently most oncologists don't believe that metastases can go to the lung, but he claims 25% of his metastatic castrate-resistant patients have lung metastases. Lutetium-177 PSMA, he's involved in this VISION phase 3 clinical trial. In order to be eligible, you must have failed 2 cycles of taxanes. And Rick and I talked about this. We weren't sure what he meant by 2 cycles. Like the typical round of docetaxel is, I believe, 6 cycles given once every 3 weeks. So I don't know what he meant by must have failed 2 cycles. Does he must have taken docetaxel twice for the entire regimen, or just 2 attempts at it? Unclear. But in any case, you must have chemotherapy and failed. You must have taken 2nd generation ADT and failed, meaning either Zytiga or enzalutamide. Must have a rising PSA and visible lesions on radiographic scans. PSMA is present in salivary glands, so this therapy of lutetium-177 is going to result in irreversible loss of saliva production, causing dry mouth. He said a lot of guys are not happy about that side effect. Of course, there are medications that can help you produce saliva, but it's pretty serious in my opinion. Mayo Clinic will soon be employing combination scans of gallium-68, PSMA, and C11 choline for diagnostic use. Okay, Dr. Jeffrey Turner, prostate oncology specialist in Marina del Rey. He has a group practice, as most of you know, with Dr. Mark Schultz and Richard Lamb. Turner is Peter Kafka's medical oncologist. He likes him. I liked him. I listened to him. I thought he was very good. He gave a talk on immune therapy for prostate cancer, and it's a bit technical, and it went on for an hour. Obviously, I'm going to give it a 1-minute summary here. The things that surprised me, he said that enzalutamide, Xtandi, has immunomodulatory effect, stimulant effects in addition to its androgen suppression effects. It's being tested with Keytruda, pembrolizumab in trials for that reason. I asked him about Erleada, apalutamide. Does that also have immunostimulant properties? And he said, we don't know yet. It's too new. Also, thus far, Erleada or apalutamide appears to have slightly less CNS effects than enzalutamide. So we're talking about maybe less cognitive deficit, less fatigue, things like that. Speaking of checkpoint inhibitors, Turner said that 5% of patients have experienced serious autoimmune reactions, and these can cause organ failure, inflammatory bowel disease, serious skin reactions, things like this that you definitely do not want to have. He said if treated early enough, these reactions are reversible. Treatment is with high-dose corticosteroids, usually prednisone. The duration of the treatment with the high-dose prednisone is usually several months. In clinical trials, a combination of PARP inhibitors such as olaparib, trade name Lynparza, Bill Burhans is taking that drug. So the combination of PARP inhibitors with the checkpoint inhibitor pembrolizumab, Keytruda, these trials have shown a decline in PSA greater than 50% in over 50% of patients with metastatic castration-resistant prostate cancer. Okay, here's his take on CAR T immune therapy, which I mentioned earlier. And Quan, recall, said that he doesn't believe it'll work for prostate cancer. So Turner says it has shown neurotoxicity in 20% of patients along with cytokine syndrome, also known as cytokine storms. These are massive systemic inflammatory responses that can be fatal in 5% of patients, but it is reversible in the other 95%. As mentioned earlier, Quan believes this will not work in prostate cancer because it is too heterogeneous. And this CAR T therapy works best with clonal cancers. So that's it. I'll turn it back over to you, Rick. So I'll make this available to anyone who wants it, and either through Jake or Rick or both. And eventually we'll have the DVD, and you can see the whole conference.
So I just want to add a couple of things and notes that I made. I didn't attend that many sessions, but that you indicated, and I'd forgotten this in the Plato trial, only about 10% of men responded to abiraterone after enzalutamide. You know, you guys often ask, well, what are we going to get if we go with Zytiga after the Xtandi? And he said about 10% responded. He didn't really talk about the other way around, so I cannot answer that. He did mention that there's a genomic testing trial going on, which is open to everybody through Fred Hutch, University of Seattle, called the gentlemanstudy.org. So anybody wanting to get genomic testing can enroll in that, and they can get a free kit. So that's kind of useful for all of us. And he said that from what they can tell right now, about 12% of men do have a DNA repair deficiency. So we've heard numbers as to how many people would respond to immunotherapy as a result of mutations and deficiencies. It's anywhere from, I don't know, 12 to 30%. And I guess it might be that when they talk about 12% of men having a DNA repair deficiency, that might be a subsector of the 30%, but it's not clear to me. There's a CAR T trial starting in City of Hope in November of this year. Turner told us that. He also mentioned that there is another alternative for germline testing with a company called NANT. They're using now NANT. So that's an alternative to Ambry and to Color. Those are the people that we've been talking about most. Did I have anything else? I think there might have been one other thing. No, I think, oh yes, apalutamide. Apalutamide, which is our leader. He highlighted the trials, and again, something we probably knew or should have known or may have read and forgotten, but in apalutamide, they found a 24-month benefit in time to metastasis and about a 25-month benefit in progression-free versus just ADT alone. So these are bigger numbers than we've been seeing with abiraterone and Erleada. So that's about it. Are there any questions to Len on what we've just on the PCRI stuff?
I don't really have a question, but sort of a supplemental comment. I recall Dr. Turner also mentioned that that they had that they were fooling around with some kind of an early test for toxicity when using checkpoint inhibitors, so that they seemed to be seeing some. It wasn't ready for prime time, but he felt it had some utility in a way to kind of prevent defense on getting too toxic with that kind of a therapy. I don't know if you recall that.
Len, does that strike a bell for you at all?
I'm sorry, I had a little difficulty hearing. He was breaking up a bit on my end.
Checkpoint inhibitors. What Turner's comments on the use of checkpoint inhibitors? I guess that would be sort of pembrolizumab or nivolumab. Those drugs. Right.
He talked.
Sorry, Dr. Turner was saying that they were fooling around with some kind of a early warning test so that they could better gauge toxicity with the use of checkpoint inhibitors. He said it wasn't ready for prime time, but it looked like it had promise, and so they were. Yeah,
for sure. As a matter of fact, I had asked him that very question. I said, "Is there any way to predict who will have these serious adverse reactions to the checkpoint inhibitors, the autoimmune reactions?" And he said, yes, they're working on some type of buccal swab, in the mouth. They're looking for genetic markers, but there's nothing yet.
Right.
Anyone else? Any quick questions on PCRI?
This
yes,
is Peter.
A quick question.
I might mention that I had that swab done in March at Turner's office, and the result came back that I was a good candidate for Keytruda. I could probably tolerate it well. So,
okay.
So it is a functioning thing. I don't know how many oncologists have access to it. He said it was through a professor or an academic situation, and not necessarily a drug company.
But Peter, there could be two reasons why they'd be doing genetic testing for Pembro. One would be to make sure that you're a likely person to respond. That's one thing. The other thing is testing for a person. They already know you're a candidate to receive it. You'll probably respond, but the other test is to see if you will have serious adverse reactions when you get it. So
that was what the swab was. I haven't had an MSI test yet, so I don't know, whether I'd be a candidate. But the swab was to see whether I would tolerate it, whether I'd have adverse reactions or not.
Oh, okay. Well, that's great if they already have it.
Yeah, and just one other thing on that.
Your mic went dead. Your mic went dead, Rick.
Can you hear me now?
Yes.
Okay, I don't know. I think it's just the internet connection. Turner mentioned that about 20% of the men to whom he's giving pembrolizumab are responding. And I asked him if all of those were pre-tested for MSI, and he said yes, they were. So they're only giving it to people that have a high MSI, and if they do, he's getting about a 20% response. John Appler, you had a question?
Yeah, two really quick questions, Rick. Thank you, Len. Did Mac Roach base his 28-month number for ADT? Was that based on some new research that's out, or what is that 28-month new recommendation based upon? And then the second question was...
The answer to that question is it's the old research from years and years ago. I think it was a Spanish study.
Okay, good. And then the second question was the gentlemanstesting.org, I believe was a site Rick mentioned. Is that kind of a general takeaway that because of this heterogeneity of prostate cancer that more and more of us should go to genetic testing in advance of considering treatments?
Yeah, I think actually that was, somebody actually said that they feel more and more that it's not a bad idea to do gene testing anyway. Does that ring a bell with you, Len? Somebody said that.
What type of testing?
Germline testing.
Well, of course, it's always a good idea for all of us. Anybody with high risk should have germline testing as well as somatic testing.
But even those, I mean, they weren't sort of tying it necessarily to high-risk patients. They were sort of saying more and more it's probably a good idea at least to get a germline test. It probably was you when he talked about the gentleman study.
That's what I heard. I heard that as well. And it isn't only high-risk people. I think it's the future coming that we should do more genetic testing.
Yeah.
Makes sense to me.
Thank you.
Yeah, so I'll put that link in the chat window. Well, let's move on. If there are any more questions, we'll handle them at the back end. What I'd like to do now is to give David Bowles about 10 or 15 minutes to talk about his own situation, which is kind of interesting. And then we can noodle with him a little bit to see if we can give him the benefit of the brains trust that's on this call. So David, why don't you go ahead and please introduce yourself and tell folks a little bit about your disease, where you've been treated, how old you are, by and large where you are in the journey.
Okay. Yeah, thank you everybody for inviting me in on this brain trust discussion group. I really appreciate it. So yeah, my name is David, of course, and I live out here in the Seattle area. I'm 60 years old. I went to my GP and got a PSA about 6 months ago, and it popped out at 17. Immediately kind of wandered into, in hyper mode, went into the standard urologist who does biopsies and got a biopsy and ended up getting a Gleason 9, all 12 quadrant diagnosis. And so that got my attention. And then decided to go out and check out the different options, and went over to Seattle Cancer Care in Swedish and a few different places and spoke to some different doctors, like let's see who I spoke to. I spoke to Michael Schweitzer, and then I spoke to Heather Chang, and a radiologist over in Swedish called guy over there. His name is right now, but in any case, for the first 2 months, I didn't do anything except change my diet aggressively, and I guess it was just changing up the fat ingestion, and lower calorie, and some basic supplements that seem to have some benefit from what I've been able to gather, things like curcumin and stuff like that. Went in and got a a PSA before I started hormonal treatment, and knocked it down to about 9.5, which kind of surprised me. I wasn't really expecting anything, but I was great that I got response. And then at that point, went on Cathedex. I basically lined up a date for doing brachytherapy with EBRT, which from all my reading seemed to be the best long-term outcome, overall survival for high risk or early prostate cancer. I was all ready to do that until Heather Chang suggested I get a color gentleman, and it came back positive germline defect, an ATM, which is the repair gene. So got me down a different pathway and started reading up on DNA repair genes, radiotoxicity, and so on and so forth. And the only thing I could really learn from the 10 or 15 papers I read, depending on which paper you read, it was either not substantial or hard to figure out whether or not relevant. And then you could find all kinds of anecdotal cases where people with defects needed.
David, let me interrupt you for a second. We're having a heck of a time hearing you. I think, and I know you're on the telephone.
Hold on, I'm going to go off speakerphone. Hang on.
Yeah.
So does that sound better?
Much better, yeah, because we
were.
Okay,
I'm sorry to put you through that. I didn't realize it was so crappy.
So why don't you go back to where your ADT got down to 9, and then you were going to do brachytherapy, and you discovered that you had an ATM mutation.
Yeah. No, actually, my PSA, I got it down to 9 with diet alone from 17. It was about 2 months of intense, total change up in my diet and just trying to kind of basically follow the Snuffy Myers, fat, change in fats and lower carbohydrate and exercise and some supplements like curcumin and a few things like that. And then I went on Cathedex in preparation for doing brachytherapy with EBRT, which from the literature that I was able to read through suggests that it has the best overall 7-year survival rate for high risk, high Gleason score prostate cancer. And that was all fine and dandy until I discovered through a color test that was what we were referring to earlier that Heather Chang was involved with for the gentleman study. And it turned out I had the DNA defect for ATM, heterozygous version of that. And that got me kind of wound up about radiotherapy and whether or not that's going to be a good format for me or not. So did some research on that and spoke to quite a few number of folks that do radiation, and a lot of them really just don't know. They're kind of like, well, maybe not, but gee whiz, it might be really good for helping to kill cancer cells, so that's a possible plus side. And then the negative side, of course, would be, all the secondary cancers you might create from, just the inability of your healthy cells to properly maintain the DNA integrity of normal cells. So I didn't really quite know what to do, and I finally thought, well, maybe at some point I'll do radiation, even though it looks like it's a better outcome long term, and I would be able to maybe possibly retain sexual function and that kind of thing. I kind of did a rock, paper, scissors on it, went with my gut, and you know how it is. Sometimes when you pretend like you don't know what you want to do, and then you finally make a decision, you kind of know. It's like, okay, yeah, I guess that's where I need to go. So I went ahead and did a radical prostatectomy after having a PSMA test done to try and get a handle on where it was outside of the prostate, because I knew from the parting table it was almost a done deal that it was, and it was. So I just had about 30 lymph nodes stripped out, and they found cancer in, under the microscope anyway, they found cancer in about 7 of them. So I'm under no illusion that I have a definitive treatment at this point. I'm pretty sure that it's floating around somewhere, based on what I know about this and all of my reading. And so I am kind of at the point now where I'm trying to figure out what's next and wondering if there's ways to get there that might give me either a durable remission without having to do radiotherapy. That's kind of what I'm thinking in the back of my head. But I've been told by radiotherapists that, the standard operating procedure here is to radiate the prostate bed and do it within 6 to 9 months of surgery and yada, yada, yada. And I just don't know if that's a wise move or not. So that's kind of where I'm at.
Mm-hmm. Mm-hmm. And where the screening indicated, I think we missed this because it was at the beginning and hard to hear you, but screening indicated to you up front that you had lymphatic metastasis?
Before I even did the surgery, I went down to UCLA and availed myself to that study they were doing down there, where they were trying to decide whether or not PSMA screening would make a difference in how treatments were done. And
Right.
so I had that done, and then that showed up. It lit up for lymph nodes and all of my prostate basically. So I went into the surgeon up at UW. And basically begged and pleaded for a surgery, even though it's not standard of care for high risk, oligometastatic. And he was willing to do it for me. So that's what I did.
Okay.
And,
So who was it that did your surgery?
let's see. His name is Bill. I don't know why I should know this, but it's one of these things about I'm on Casodex and Lupron, and it's really kind of knocked me down in terms of my mental acuity. I really feel like I'm operating on about 5 French fries short of a Happy Meal. But here, his name is well, he's the #1 surgeon down there at UW. But that's all I know. He's affiliated with.
Okay, but
his name is. Sorry.
You had it done at UW.
I did, yeah.
Okay, that's fine. Yeah, no, I just.
Oh, sorry. His name is Bill Ellis. Yeah.
Okay.
Bill Ellis. Yeah.
Okay. So. Okay. So I just want to make one comment, and then maybe you can think about what you want to ask the guys, and then we'll throw it open to the guys. But I mentioned to David, I mentioned Professor Bill to David, and Professor Bill has a DNA repair mutation with BRCA2, and he has a theory that the DNA repair mutation is what caused him to have such significant adverse effects to radiation. So it was interesting for me to hear David's thoughts, which kind of concurred with that just from the gut. And so hopefully David and Bill can talk a little bit. But I do think that probably there's good reason to be more careful if you find you do have certain mutations, even though there's no hard evidence that we have. It's all anecdotal. There may be reason to avoid radiation if you have some of these DNA repair mismatch mutations. David, what would you like to ask the guys? The guys in this group are mostly all recurrent or advanced guys. There's a couple of guys that are just starting out with high risk, but many of them have been through more than one treatment, and are looking at managing this disease for the rest of their life. So
right. I've got so many questions. Being just kind of a newbie into this, I guess, kind of in my 30,000 foot feeling about this overview is that I really do think in 5, maybe 10 years, there'll be some really kick-ass treatments out there. So that gives me a little bit of hope. I also think that it's going to be a game of, speaking of games, I read an article just a summary of an article in JAMA about this guy who was like a computer geeky guy who was talking about, and he was also a doctor, was talking about how a lot of the cancer oncology community kind of treats disease progression, in sort of a kick the can approach where you try this until it doesn't work, and then you try that until it doesn't work, and then you do this until it doesn't work, and hopefully you get your 5 years or your 8 years or whatever, and that's just kind of how they look at it. And he was kind of postulating that maybe with this kind of cancer, it might not be a bad idea to use game theory, where you being that your opponent is unpredictable, and so why should you be predictable? Like, in other words, just have this A to B to C kind of linear approach to things. Maybe there's a benefit to being a little bit unpredictable about how it's treated. And to me, that's just, it kind of seemed to make sense. And then I was thinking about, like somebody like Snuffy Myers, who's suggested that using combinations of drugs, which was never done before, instead of doing the linear stuff for AIDS, ended up with giving people quote unquote durable remissions for 10 or 20 years, whereas prior to that they were all dying. And that maybe some of that same kind of philosophy could be applied to prostate, high risk metastatic prostate cancer treatments, which I think probably all you guys here have probably seen articles about that or talked to people or whatever. And I don't really know what that means at the end of the day, because when you go to these standards, the standards of excellence, sort of, if you will, the folks are all really smart and, but they're all kind of like level 1 people. So they kind of say, well, this is what we know. We don't really know that radiation could be crappy for you. So we're just going to kind of roll the dice here and assume that you'll fall within a statistical Bell paradigm of, distribution, and you'll be okay.
So,
that's kind of how it, and that's kind of what you get.
So who would like to take, there's a bunch of guys I think have thoughts on that. Who'd like to go first?
I'll jump in. David, who's managing your care? Do you have a genitourinary medical oncologist running the show, or who?
Yeah. Well, I was actually working with Dr. Schweitzer, and I switched over to my first meeting with her as my primary is actually tomorrow, and it's Heather Chang, and she's a genetic oncologist, prostate, and specializes in prostate. So,
is she willing to think outside the box, as you described?
I'm going to find out. I don't know. I'm. It's kind of a high, thin air area of prostate cancer, I believe. The whole genetic thing is the latest and greatest. So I think she probably is. But then again, I know these folks are all, they're all credentialed and they all publish. And, sometimes you're kind of constrained a little bit by your institution, because they probably frown upon, the Wild West kind of approach to things to some extent, I would imagine. But I don't know.
When you mention that you have oligometastatic, does that mean something beyond the prostate bed, or are you just referring to those lymph nodes?
Oh, yeah. So the PSMA showed all of them in the prostate bed, with one in a lymph node up a little bit higher, about 2 centimeters higher, closer to the para-aortic artery. But I honestly would say that, even though that's what lit up, I'm sure there's probably smaller clusters that aren't, that you couldn't pick up on PSMA yet. That would be my thought anyway, that might be elsewhere. Who knows,
Okay, this is Peter Kafka. I'm always on the call, and I live on Maui, Hawaii. I have a very similar situation to you, although I didn't have. I had my lymph nodes removed with the prostatectomy, but they were negative. But now I've got metastatic disease in the abdomen from lymph nodes. So I've gone through process. I mean, the standard of care process. When I had my prostatectomy, there wasn't any genetic testing, but I did it later. I had it later, and I do have a marker. But I had the prostatectomy. I made it 11 months, and then I had follow-up IMRT radiation. And then 2 years later, now I've got recurrent disease, and I'm headed to more radiation in my abdominal area. So I'm not concerned about it because, I think there are ways to manage this. I don't know I don't think realistically for me anyway, I'm going to get a cure or a long-term remission. If I can get 2 years out of a certain treatment, I'm pretty happy with that. And I'll keep managing. So I stay optimistic, and I'm not down on it, but I'm cautious, and I'll spend the rest of my life looking over my shoulder and keeping up to date on all the treatments that are possible.
Yeah. So did you jump on the hormones right away?
I did, but I was symptomatic. I was a little different than you in this score. I was on a catheter for 8 months before I decided on surgery.
Oh yeah, so you had a really big prostate.
Yeah, well, no, I just had a bad retention problem. It wasn't that big.
Yeah. So did you do combo hormone?
I did.
Which one?
Lupron and Casodex for 8 months.
And then even with that, it started rising after 8 months?
Yeah, I did it for 18 months, and now I'm on Lupron and Zytiga.
Is that, are you faring well with that in terms of how you mix? Yeah?
I'm doing great. I go to the gym almost every day. I'm feeling great. I'm doing well.
Awesome. So you didn't get some of those side effects that I hear about people from Zytiga?
Not on Zytiga, but the first time around on Lupron and Casodex, it knocked me off my feet. Yeah, I felt it. Same way as you are.
Yeah. Yeah, I feel like I'm just really under the weather all the time. But
so if you can do intermittent, if you can talk to Heather Chang and see if you can get on an intermittent program between treatments, that can help a lot in terms of your outlook.
Yeah, but you're not going to be eligible for that until you've really done at least probably 12 to 18 months, if not longer, in your first stint. I mean, you don't want to move on to intermittent too quickly.
Right.
Once you've got it established. Who else would like to respond to David?
So this is Don Price. So
hi, Don.
Hi. So if you want a second opinion, I would suggest Schultz and Turner down in Marina del Rey. And so so they had me on, within 4 or 5 months after the prostatectomy, they had me on radiation, Zytiga, and would have had me on chemo all at the same time. But for various reasons, I didn't do the chemo. But so they would be ones just to get a second opinion and say, what would somebody that doesn't go sequentially, what would they want to do in your case? Yeah. And they'll do telephone also.
Okay, yeah, I mean, it's no problem to get down there. I'm in Seattle. It's actually a pretty easy flight to make it there.
Right.
So you're seeing Dr. Turner then, I take it?
I started, normally I see Schultz, and then this last time, just last week, he was getting ready for the conference, so I ended up seeing Turner.
Right.
And I'm
sorry, did you say you did a prostatectomy and then within 6 months you were on hormones?
Well, within 3 months on hormones, and then including Zytiga instead of Casodex, and then IMRT 6 months after the prostatectomy. So prostatectomy, 3 months later on hormones, and then 3 months after that, the IMRT.
Yeah, no. on the hormones, you're on Lupron and Zytiga, right?
Firmagon and Zytiga.
Oh, Firmagon. Yeah. You do the once a month shot. How does that work for you? Is it pretty painful?
Once a month for 18 months. Started out fine. As time went on, it got worse, but I made it through 18 months. That was starting in 2014 or so.
So did you follow the thought process that you want to do the radical prostatectomy and see where your baseline PSA is before you do anything, or was it more like, no, let's just go with this. We know it's an issue. Let's rock and roll.
Well, at the time in 2014, I mean, I just talked to people and decided, let's just do the prostatectomy and see, what's actually there, I guess was the thought process. I don't know if I would do the same thing today. I mean, I don't know. But back then, that's what I did.
Yeah, and then did you monitor your PSA right after surgery to see kind of where you were at? Or
Well, it got down pretty low to 0.02.
And then you sat on that until it started to move, or did you just say no?
No. As soon as it did not go to undetectable, the idea, because it was high risk to begin. I mean, it was in seminal vesicles. Didn't have anything. Didn't find any outside the seminal vesicles in the prostate bed, but had a margin, had 4+3, and so at that time the thought was, let's just do all this stuff.
Right, and that was through with Schultz and Turner. That was with
Schultz and Turner, but also I'm essentially outside of Denver, but also the medical oncologist who specialized in prostate cancer here concurred with that. So they came up with the idea. He said, "Yep, sounds like a good plan," and so we did it.
And then did your insurance company push back on you, because supposedly Zytiga is for folks after they've shown castrate resistance and all that crap, right?
It did not push back, and I didn't ask questions.
Yeah.
So whether the doctors fudged on what I had, I just didn't ask any questions.
Yeah.
They paid for, I think the copay was like $200 or $100 or something a month.
Right. So Zytiga
Can I just interject here? I believe Zytiga is approved for hormone-sensitive metastatic prostate cancer, and your situation is similar to Peter's in that I think they would consider you metastatic, even though it's not bone metastatic.
Well,
So
it's generic now too, isn't it?
No, not quite. But let me interrupt. Let's just hear from one more person, and then I want to move on to everybody.
Sure.
Anyone else like to talk to David?
It's Larry Fish. Just something quick.
Yeah.
Can you hear me, guys? Guys, okay. David, you might be interested to take a look at the website clinicaltrials.org and just look at prostate cancer. There are a number of trials I've noticed that are going on where they do this like a Wild West kind of approach you're talking about. Maybe it's not for your case exactly at this point because it's more for a castrate resistant, but where you're on you're on Zytiga for 6 months and then, or 6 months, and then you're on Xtandi for 6 months, and then they go try docetaxel for 6 months, and then they go back to. So there are a number of studies that are starting to look at kind of a floating, changing approach and see how that compares. I don't know if there are any reports out, but if you just, I think you sound like you could really understand just by looking at those trials at clinicaltrials.org and look for some interesting studies and maybe start to just follow what's there and see if any of those things go along your way of thinking.
I appreciate that info. I would certainly like to see what some of the options are out there. I certainly can't afford it out of pocket. I mean, like even just playing around with the idea of Provenge, which I would do in a heartbeat if I could get my hands on it, just because the toxicity profile is almost nothing. So it's like nothing venture, nothing gain. And some of the studies that seem to be coming out, and some of the guys at the prostate convention were basically alluding to the idea that early treatment, low burden disease is a lot easier to get your arms around and keep down than obviously highly involved disease. And so,
Right.
$100,000 doesn't quite cut it for me. I'm not of Medicare age, and they wouldn't give it to me anyway because I'm not quote unquote castrate resistant. So at least not that I know of.
Right. There are a lot of good help programs. And in fact, one session that I attended, which was just for support group leaders, Janssen has done a state by state, even county by county listing of financial assistance. This is not specifically related to Zytiga, this is general. So don't, before you rule out a drug, if it is prescribed to you on financial reasons, make sure you do a lot of homework, talk to us because we know where there are resources. I don't want to spend a lot of time talking about that right now.
Right.
The last thing I want to say to you, David, is that there are 2 emails for you. One from Professor Bill addressing the radiation and mutation situation in response, I guess, to your email to him earlier. I haven't read it, just saw that it's there. And secondly, I just sent you an email with a link to the hormone therapy pamphlet from UCSF that is a very good and thorough explanation of what to expect and with some good ideas on some mitigants for some of the side effects. And what I would say to you is that as much as we regret having to welcome you to this group, we're very glad that we found you and you found us. And as most of the guys on the call would tell you, it's worthwhile to keep coming back whenever you can. And, you can always ask your questions going forward.
I appreciate that. Thank you so much, Rick. And thank you everyone for inviting me into this little exercise and learning.
Okay, with pleasure. So I'm going to run down the list quickly. We've got about an hour, a little bit less probably at this point, just under an hour. So let me see who would like to talk. I just want to point out for those of you who are online, and several of you are today, that in Rob's honor, we've renamed this room the Baniscus Room. We have a second room. If I see any of you guys in that second room, I'll tell you who we named that room after. But this room going forward will always remind us of Rob. And I'm really glad to have his presence with us every time I meet. So, Rich Jackson, would you like to talk about anything today?
I just want to unfortunately welcome David to our group and let him know that if he's got some emotional issues he'd like to talk about, tomorrow night's available.
Correct. Tell him more. Don't stop there.
Every Wednesday night, 8 o'clock Eastern time, we have the Inner Conversation, which addresses the emotional side of any type of cancer. The things that bother us, that keep us up at 2 in the morning, that scares, where do we find happiness now? My life sucks. And it's a chance to vent, to hear other people that have maybe found a slightly different path to get back to finding glad or finding happiness or, back to where we used to be. It's a good call. It's about an hour and a half. Again, it's 8 o'clock Eastern.
That's a phone call?
Exact same.
Yeah.
It's a computer or phone call. You connect to it exactly the same as you connected to this call. Everything's the same.
Same number, same everything.
Same everything.
Sir.
It's 8
Okay.
o'clock on, it's 8 o'clock
8
Eastern.
o'clock Eastern.
Okay. Cool. Makes it handy that it's the same number and the same access code. I mean, I get kind of lost after about 2 memory items, so that's good.
Rich, anything you'd like to talk to us about?
Running into some bleeding issues that we can come back to if you're bored.
Okay, well, we'll come back to you. Don Price, what can we do for you, Mr. Price? Anything?
Nothing. I don't have anything, and what? And I
No.
will.
What did Dr. Turner say to you? You look great.
Yeah,
No?
he said, yeah. I mean, he didn't have a whole lot to say, but no testosterone, and just keep on doing what I'm doing. So.
Okay. Okay. Len, anything for you?
No, thank you, sir.
Jake, would you like to tell us a little bit about your situation momentarily?
Not really, Rick. I'm kind of tired today. I was up late and woke up early.
Okay.
If there's time, I guess we can go into it.
Well, if not, we're going to get you next time. You know that.
I know that.
Okay. Larry Fish, anything for you?
Not this time, thanks, Rick.
Okay. Les, anything for you?
Not today, thank you.
Okay. Mr. Crockman, anything for you there in Tennessee? Are you with us, Jay?
I think I saw that he left some time ago.
Okay. All right. Brian Heisey, how about for yourself?
Nothing tonight. Thank you, Rick.
Okay. Jake, it's not looking good, man.
What's that?
I said it's not looking good.
You're going to have to testify.
Right. We're getting a lot of people that don't want to talk.
Okay, that's all right.
John Appler, anything that you'd like to discuss tonight?
No, I want to hear what Jake has to say.
Okay. Okay. Paul Frieda, anything for you?
Yeah, I'd like to talk about something.
Okay. Dennis Correa, anything for you?
Nothing for me, Rick. Thank you.
Okay. And Peter, anything for you?
No, I think I'll pass tonight. I'm pretty good.
Okay. Oh, Ken Anderson's on. Hey, Ken, would you like to talk about anything? Tell us how you're doing.
And I don't really have any new news. I could talk, but I don't have anything to say.
But we like to hear your voice. We like to know you're well.
Send the heat away.
Okay, I'll see what I can do. I'm in LA right now, so I don't have to worry about that. Have I missed anybody? Have I failed to check in with anybody?
Did you get Les?
Yes.
Okay.
I did. All right, so right now we're gonna talk to Rich, we're gonna talk to Paul Frieda, and then it looks like we may have to talk to Mr. Hannum. So, Rich, go ahead, please.
Okay, just for the background, had high dose brachytherapy in January 25, IMRT external, and ended in March. Did about 3 months of Casodex and Lupron. Currently doing Eligard. Changed urologist, and he told me it was cheaper. Second shot hurts like hell. I think they screwed it up. But what I'm running into starting today is since the radiation, typically the bowel movements are small and more frequent, 3 to 5 times a day. This morning, I had a bowel movement that probably had about a blood work test tube of blood, bright red, fresh. Had 2 movements after that pretty much 90% blood that was about the same amount, about like you draw a test tube for blood work.
Right.
Got a call to the doctor this afternoon, and they asked if I had hemorrhoids. I never had an issue, and their thought was, well, not sure. It's fresh, so it's lower. It's not a large amount to get scared about, but it's something to be concerned about. So their recommendation is watch it a couple of days and see if it gets any better or if it heals itself.
Right.
Wondering if anybody else has bumped into something similar.
Well, I have for sure. I can't remember how soon was my. I'm afraid I can't remember how soon my first incident was, but I've wrestled with radiation proctitis for about 10 years now. And as long as the blood is very bright, it doesn't bother me at all because it didn't bother me even in the first place because I suspected that was where it was coming from. But the likelihood is that there is tissue in the rectum and the bowel that has been irritated by the radiation. And in fact, when I've had a sigmoidoscopy and a colonoscopy subsequently, I've seen it. One thing that Mac mentioned, and I think it's worth repeating, is that, and he was certainly very strict about this with me, is that if you think you've got any issues there, it's not smart to get a colonoscopy. You want to have your GI doc speak to your radiation oncologist about the risks of doing a colonoscopy. And he conceded and let me do a sigmoidoscopy, but it was about 6 or 7 years before I could do a colonoscopy because there are risks when the walls of your colon have been compromised by the radiation. So I'm not a doc, I can only tell you about my experience, but it didn't bother me. I pretty much put it down to radiation proctitis, radiation damage of the tissue. And, the bad news for those of you on the call is that I'm still living with that. And that's the major side effect that I've been left with. I think my bowel was never strong in the first place, and it's been significantly weakened. So I would tend to agree with your docs. Don't get yourself too anxious. It's par for the course for a lot of guys. Anybody else want to comment on that? Dennis, haven't you had these issues?
No, I think you're confusing it with the diarrhea that I had.
Oh, right. That was different. Yeah.
I have a very similar case as Rich Jackson, Rick. Rich, how far out are you from radiation?
Last external dose was 2nd of March.
Okay, so yours came on sooner than mine. Mine came on about 15 months post radiation, but I had the exact same pattern, more frequent bowel movements and very small, which reflects the narrowing of the colon due to the radiation proctitis. I did see a GI man I also had the bleeding like you have. One thing you need to keep in mind when you say a full tube of blood, just 3 or 4 drops of blood into the bowl can turn the whole bowl red. So it's probably not nearly as much as you think. Now I went to.
It was solid and it was formed. So, but yeah, I understand.
Yeah. Okay. So I went to a GI doc and just to get his opinion, and of course, they want to sell you something. So he proposed argon gas laser treatment. I didn't have it done. I just consulted with him about a month ago. I seemed a little too anxious to want to do it. And as Rick mentioned, there are some risks. You could have a perforation when they do the colonoscopy if they're not careful. They should be
not interested in a bag.
Sorry?
Not interested in a bag. So nobody's sticking anything in the wrong spot yet.
Right. Okay. I don't know if anybody explained to you why this happens. So you do get what is called ischemia, which is the tissues in the colon after radiation become ischemic. There's insufficient oxygen. So your colon says, hey, there's not enough oxygen in the lining of the colon. We've got to build more blood vessels and, get some more oxygen there. And of course, that just keeps sloughing off. And that's the blood. Now, Bill Burhan's, I think you know him, he told me he had some pretty serious bleeding, rectal bleeding following radiation, but eventually it stopped. He said after, I don't know, I can't remember, a year or 2 years. Rick, unfortunately, still has a problem. I'm hoping, like you, that it'll just go away. So I'm hanging in there. Oh, and one other thing. I have found that taking medical marijuana has helped. I guess it has some sort of anti-inflammatory properties. There's something they call slips. You just put it under your tongue, and at night it helps. I actually started taking it just for sleep issues, and then just coincidentally noticed that bleeding had stopped. So that's something you might want to investigate.
Can I chime in here? Just a real brief thought. I'm no expert on this topic other than having had 3 pretty horrible colonoscopies in a row. And I think it was, what's the main guy's name? Dr. Moyen, is that his name? The kind of comic relief guy? Yeah. He was talking, I think it was him who was talking about, like, for colonoscopies in general, that there's a new Cologuard test that you can just kind of skip out of the whole colon monitoring process and have a better sensitivity for issues that might be creeping up. And the other thing that I was thinking about was that I'd read an article in Journal of Clinical Nutrition about I think it's butyrate. It's supposed to be really helpful for lower colon bleeding as a result of radiation therapy, and also hyperbaric oxygen, which apparently is an approved treatment, I think.
Right, it is. What was the first thing?
Butyrate. I have no idea why that's
Gatorade.
Yeah.
Okay. Well, we do know someone who tried hyperbaric. I don't know how successful it was, but they did finish up with significant eye issues, which is a secondary comorbidity from the hyperbaric that they don't mention to you. And this guy actually finished up with, can't remember, what was it? Was it a cataract or a detached retina or something like that?
Cataracts.
What?
Cataract surgery.
Cataract.
Yeah. Jim Cameron?
Yeah, Tennis Jim. Yeah. So yes, it is a solution. And the other thing is this argon laser treatment where they cauterize has been around a long time. It wasn't something I wanted to do, but I know people that have done it, and basically they're just cauterizing the wall of the colon so that it doesn't leak anymore. But you know, for me, I've just decided there's no pain associated with it, but you know, it's not pleasant, and there are other issues. But so I want to I just want to give you some comfort, Rich, and tell you don't knock yourself out. It's you know, it's manageable, but it's going to be around there for a while, probably.
Well, Rich, this is Jake, but you know, David made a good suggestion. Cologuard. You might want to talk to your doctor about that. It's just basically you've probably seen advertisements on TV where you just give a stool sample and send it to the lab. Now, whether bleeding in the stool is a disqualifier, I don't know, but that, you know, it might give you an indication of whether your bleeding is coming from colon cancer, which is why they would want to do a colonoscopy, or if it's from the radiation.
Yeah, I do believe it's
colonoscopy. I had a colonoscopy just before initial treatment. Late last year, I had a colonoscopy. They didn't find anything. A couple of polyps.
Okay. Well, you don't want to have another one for sure.
Yeah, I honestly think going forward.
5 years. They were happy enough. They said come back in 5 years.
Well, somebody was talking about doing a colonoscopy to rule out something, and the
Well, I was
day
just thinking
after radiation. Who was talking about that?
No,
That was me.
We were just saying that you have to be very careful if you have a colonoscopy.
Right. Now, the main thing I was looking for as a first occurrence, it was not unexpected. It was more, okay, this is interesting, but I'll give it a few days and see how that goes. I wasn't getting excited, just another thing to put on the watch list. But I appreciate all the input. Thanks for the help.
Okay, so let's move along to Paul Frieda. Paul, you have something on your mind. Talk to us.
Yeah. Well, just a background for some of everybody. It's about in 2014, I had a prostatectomy, and unfortunately, a couple months afterwards, my PSA was not undetectable. It was 0.22, and so I elected not to do radiation, taking the advice of Dr. Walsh from his book, saying that if your PSA is above 0.2, you're probably metastatic already, and it would be pointless to do radiation. It was a difficult decision. Some people were telling me, do it, and other people are saying, you know, follow the advice. So anyway, I went and spent, took a while, about a year before my PSA got to a point where I had to go on Lupron, and I've been on Lupron now for just about 3 years. And my doctor and I have decided that it might be a good time to take a Lupron vacation. And so what I'm wondering is this. The standard protocol is when the Lupron fails, you go on one of the 2 or 3 secondary drugs, enzalutamide, Zytiga, etc. And then when that fails, maybe you have Provenge that you might try. And then eventually you end up on chemo. And for some people, chemo works for a long time. For other people, 2 or 3 different chemos don't work. And then you're sort of at the end of the line. What I'm thinking is, now that I've been on Lupron for 3 years and the cancer is dormant or all dead, whatever cells there are that are resistant to Lupron, now would be a perfect time to do chemo. Just blast I'm just willing to, you know, lose my hair and feel awful for I don't know how long, but it seems I have my best shot now. It seems silly it doesn't make logical sense to me to wait until the cancer is starting to roar and everything else has failed, and then you try chemo. It seems to me that doing chemo now would be a smart move. So I'd like to get opinions on that.
Anybody want to comment on that one? It's an interesting thought.
Well, just to kind of chime in about what I was saying earlier about how, gaming theory where you try and mix it up and not just play kick the can until you get to that point that, sounds as reasonable as any other rationale that, for therapy approaches that I've read about. I've read, I think at the seminar, I heard that there was a great deal of conversation about how taxane actually creates an immune stimulation as well at the same time, so that it's useful when it's used with other things besides just hormone therapy. That there's an additive effect or whatever.
Paul, can I say something, Rick?
Go ahead, Lynn.
I haven't had chemo, but my understanding from, I think it was called the Charted trial, was that for patients with high volume disease, lots of cancer, that chemo worked well. But for those with low volume disease, it did not work so well. One thing you have to keep in mind, chemo is not without its own risks, because it can weaken your immune system and it can cause peripheral neuropathy, which is extremely difficult to treat. And that could affect your quality of life. I think that the Charted and Stampede trials demonstrated that you were better off with the second-line anti-androgens like Zytiga and enzalutamide rather than chemo if you had low-volume disease. Does that ring a bell with you, Rick?
Yeah, it's certainly right with the high-volume disease. I still think, if I'm not mistaken, that there was a better response from chemo than from the second-line anti-androgens, but it wasn't as different. It was significantly different with high-volume disease, but I'm not sure about that. You could be right. I need to go back and look at the trials. But you raise a very, very good point. Peter, what do you think? Because you have a situation that's comparable to Paul's.
Well, if it was me, after 3 years of hormone treatment, I would take a break for a while and just get monthly PSA checks, monthly PSA and testosterone checks. And, when you start seeing a creeping rise, even though it's at low levels, just monitor it. And I'd try to get in on a high tech scan, a gallium-68 or something like that, so you can kind of see what's going on and where the action is. And then I'd talk about what the game plan is. I wouldn't jump into chemo right now. As Len said, there's some pretty heavy duty side effects, and it might be the way to go, but I'd give it some, if it was me, I'd give it some time to kind of monitor the situation and watch it.
Well, I know it's going to be rough, but I'm willing to, walk through fire to I've got a 12-year-old daughter that I'm trying to make 6 or 7 years, so I get her into college, and then, then my job is done. And so I'm willing to do anything if it'll improve my chances. So it seems to me, how do they know in low volume it doesn't work? Because if it's low volume disease, your PSA is probably very low, and you're not going to see much of a change. But if your PSA is high and you've got high volume, they can see it drop. They can see, oh, you went from 97 down to 22.
Well, Paul, let me answer that. When you're doing a trial like that, and I'll send you the Charted trial afterwards, and Stampede. You can look at Charted, you can look at Stampede, but there are lots of measurements. Don't base your conclusions don't base your assumptions as how they measure just on PSA. They're screening on a regular basis to see what the impact is. So they're looking to see whether the chemo is reducing the Mets. They're looking at other markers like alkaline phosphatase. They're not just basing it on PSA.
Okay.
Well, I think they're also doing something where they're measuring. These are following these people long term, so they're actually looking statistically at how they survive as a group, their overall survival. And they measure that as a some percent increase or decrease compared to some other group, right?
Well, I think what they're doing. No, I would say that they have a sample size, and they're measuring the endpoints, whatever they've established those to be in that sample size, and they're drawing their conclusion. So, the question is, how big was the sample? Did they have enough people in each arm, et cetera, et cetera? I mean, that's how they're drawing their conclusions, David.
Mm-hmm.
I mean, they're not extrapolating to say this is reporting on the results they found in their particular sample.
Right. So like some of the studies that I've been looking at, they keep talking about OS or overall survival or
right,
whatever for a particular treatment and however long they last compared to some other group is their percent, like they got an extra 28 months with Zytiga or whatever compared to
right, but that's compared to the control arm. So they're comparing it. So they may have 500 people in the trial, and they've got 200 in the control arm and 300 who are getting the treatment.
Yeah.
So go ahead.
Yeah, I would wait. I'd reiterate. I'd wait and have a scan, and you're not going to wait until your PSA goes up to 1,000. I mean, it's going to be under 1, and you can get a scan. And if the action is in the prostate bed, and you haven't had radiation, you might be a great candidate for radiation at that point. And it might be a better way to go than right. I mean, you can always do chemo. It's not like you've lost your opportunity, and you can do it at a very early time.
But isn't that true? Isn't that true of Zytiga and enzalutamide? I mean, in the chemo for as much as you can stand it, giving yourself the best chance of killing everything that might be there. If it comes back, you can then go on the Zytiga and enzalutamide.
If you're still sensitive to it, yes, you can.
Right. So it seems to me, but we know that Zytiga and enzalutamide are not going to kill everything, but the chemo might. Chemo it kills good cells, right? I mean, so you're subjecting yourself to a really brutal treatment, but you might just get that. See, there's a very small amount in there right now because my PSA is undetectable, and I've been on Lupron for 3 years. All those Lupron sensitive cells, they're either dead or they're totally dormant, and now while you've got them in their weakest point, now you send in the cavalry, and it seems to me like that.
Well, yes, but you've never had radiation. Radiation kills cancer cells too, and if you can find out that your cancer cells are all, say, within your prostate bed now, you can do.
There's no way I can know that, Peter.
Yes, there is. With the high-tech scans they have now, they pick up under 1 PSA. They can tell exactly where they are, pretty much, whether they've migrated out of the prostate bed or whether they're still there.
I mean, if it went into one of the bones of my legs, they'd be able to see it there?
Yes, usually they can.
But isn't there some caveat that, or at least I remember hearing a radiation guy talking about this, that, they can only kind of tunnel down to so small of a size before there's not enough signal on the marker, like the luteum or the gadolinium or gallium marker, or with the C11 marker, that they can only get so small, and then there's just not enough signal there to differentiate between 20 cancer cells versus, I don't know, 1 million, which might be a millimeter across or something, right?
Well, that's the advantage of the gallium-68, that you can wait till it gets to about a nadir of 1, and you can probably get a pretty good result. If you can wait till 2, you get a better result. But 1, you get a very high percentage rate of catching things.
Paul,
Yeah,
I'd like to, my understanding, and Rick and Peter and anyone else can challenge me on this because I'm not at all sure, but I've never heard of chemo curing anyone with prostate cancer. I've heard of it doing that for other types of cancer, but not prostate cancer.
That's a good point, yeah.
It's been proven to extend survival and progression-free survival, just as the second-line hormonal agents have, but I've never heard of someone being cured with chemo.
Well, that could be because the protocol has been wait till the very end for forever. I mean, and it still is now, I think, right? Most doctors are not going to give you chemo until you failed the secondaries and maybe failed something else. But
the trials
there's no history.
I'm sorry. The trials we mentioned earlier, the Charted and Stampede, they did show that for certain patient groups, namely metastatic high-volume prostate cancer, first diagnosis, chemo works very well. Doesn't cure, but it works very well. But yeah, other than that, then you have the situation you're talking about where it's usually used at the end when they've run out of other options.
I just want to, I mean, I read this somewhere, and I don't know how true or false it is, but it kind of makes sense, is that the way like the taxanes work, or what theoretically, is that they target rapidly dividing cells. So cells that are undergoing, rapid division are susceptible to these drugs they're like mitosis inhibitors or something like that. They interfere with the mitotic process. So like folks that have rapid PSA doubling times, they've got rapidly dividing prostate cancer. And my thought, or at least what I've read or here and there, is that it seems to be more useful for that, I guess. What I read, because there's supposedly early prostate cancer is considered a cold cancer, where it doesn't really divide very quickly until way down the road. Of course, most of us here are high risk metastatic, so that probably wouldn't apply. I mean, we're not really cold cancers anymore, I guess.
Yeah, that's true, David, and that's a good point for Paul to think about, because prostate cancer, particularly yours, is very slow growing, and as David just said, chemo attacks those cells that are rapidly dividing, and it's not going to hit the slowly metabolizing, slowly growing prostate cancer cells. So
something occurred to me that we haven't talked about for quite a while on this call, and that's the BAT, the testosterone. I forget what BAT stands for.
Bipolar androgen therapy.
Yeah. I'm thinking that might be something that Paul would want to look into. Since his PSA is low, presumably the cancer cells are dormant, possibly feeding them a high dose of testosterone, and then, it might end up killing them, the ones that are remaining.
Well, I think the one problem with any of these ideas for Paul getting more treatment right now is he's got no idea if it's going to work, if it's working or not, because there's nothing to measure.
Right.
He doesn't have PSA. He doesn't have any METs that can be seen. He's not going to have any bone activity. So how? And he has very few cancer cells because he's been on the androgen therapy for so long. So how would he even know, if he did a treatment, whether there was any benefit from it?
Well,
I'd be willing to do it even if I don't know, because, taking the chance that I'll find out later. In other words, if I do the chemo and then, I end up getting 3 or 4 years, after I stop the chemo, then the chemo probably helped.
Yeah, I mean, the problem is you've got no idea if the chemo helped because you may have been in the same place without the chemo.
True. True.
You just don't
I was
know.
just I was throwing out the BAT as an alternative, since Paul seems to be kind of fixated on doing something, throwing the sink at the whole thing, rather than
Well,
doing what
look,
other people are
here's
counseling right now. Just hold off for a while.
here's where I guess I come out. If there was anything to Paul's theory, I just have to think that somebody would have run a trial.
All right.
Now, I know that you don't run trials if you're not going to make money, and you're not going to make money just by adding chemo at this point, so it's hard to fund.
Plus, I don't think you get a lot of people signing up for that. You know, people that are undetectable PSA, you know, standing in line for chemotherapy. You know.
Right.
What does your doctor say, Paul?
I actually haven't asked him about the chemo. And that was my other question. Is there anything that will absolutely stop me from getting the chemo, other than my doctor's opinion? And I'm like, I may ask him, and he say, no, I just don't think that's going to work. And if I insist, will he be forced to give it to me or not?
No, he may just send you to it. He say, I don't consider that appropriate treatment. If you want that, you'll have to go elsewhere. It's probably what he would say.
Right.
Right.
Yeah.
You can't force him to do anything.
Right, of course.
Right.
But I have to have his okay in order to get like any drug for right.
Yeah, I'm sure you could find somebody somewhere that would do it if that's what you wanted. You know, you might have to shop it.
Right.
Larry, I think that if there's no protocol and there's no evidence or any trials, the doctor would be a little reluctant to prescribe a serious treatment plan for something that there's no known reason that that's appropriate at this time. And, you know, the only two places you see it working is, you know, right at the beginning, if you come in with high volume metastatic and you show up, they can say, do it early on right away along with ADT therapy, or waiting until you've tried therapies or treatments and later on the PSA starts to rise later. They don't have any evidence. It seems unlikely. And the other two other things. One thing is, what about the cost? Do you think insurance companies are going to say they're just going to pay for that? Something you want to do, like as taking a chance with your personal theory? And the third thing was that you know, the effects of chemo on your own system are cumulative, and this is something you may need to think, you know, may need to do if your PSA starts running and Zytiga and Zalutamide and whatever immunotherapies are around when that happens start to fail. They may go to this kind of last resort, and you've already been doing, you know, other courses of taxane, and then you go back, you those cumulative effects. I mean, the kind of neuropathies that I face and problems with my nails, the likelihood is that if I would go back and do it again, those are going to come back much worse and get rapidly. So I think there's a lot of risk in doing this, and I don't know. It's interesting to see if anybody has tried this, but otherwise, I think it's high risk.
I would personally, if I was really just hell bent on like trying to eliminate something that I might think is there, so you know, or whatever, I'd try something less toxic like Provenge or something like that. You know, just thinking out loud.
Yeah, well, you have to be castrate resistant in order to get Provenge. I'd have to wait until the Lupron failed, right?
Well, I got to tell you, there's a bunch of people I know that have been on Lupron and gone off, and then as soon as their PSA starts rising, they've managed to get Provenge.
Oh yeah.
Oh yeah. So, you know, you might bear that in mind, and you know, if and when it does happen, we can talk again about whether you would be eligible for Provenge. You might find you are.
But Provenge doesn't have a whole lot of a success, does it?
Who said that?
Well, I don't know. My impression is that like maybe 1 in 10 or 1 in 30 people actually benefit from it. But I don't know what the numbers are. Am I misinformed?
Right, but where are you getting the information from, Paul? I mean,
just my impression. That's all.
Right. Well, here's the thing with Provenge, and a lot of doctors talked about Provenge over the weekend, including Dr. Kwan, who wouldn't give it to his dog. But then I'm not sure I would recommend my dog to go to see Dr. Kwan, so it probably doesn't make a lot of difference. The issue with Provenge is that it's kind of like chicken soup. It doesn't hurt, and maybe it helps. We don't know how much it helps. What we do know is if you're going to do it as early as you possibly can. Because there's evidence of what it can do and what it does do. And we know originally it did have an impact, but it had a very small impact on men who are at very late stage in their disease. So if you're going to do it, don't do it late stage, because it's not going to have enough effect to reverse the disease. What we think is that it may have enough effect to constrain the disease if you take it early in the disease process.
It also has very little effect on PSA, but that doesn't mean it's not working.
And the reason it has a low effect on PSA is because it doesn't kill the cancer cells.
Right.
It stops them from spreading, and that's different. So the way it works is it constricts the cancer cells that are there, and it doesn't allow them to go anywhere.
Correct.
Okay.
Okay.
Another thing too is,
yes.
Did I hear that you have high risk prostate cancer or moderate risk?
My Gleason is 4.4.
High risk.
So, have you done any of the genetic stuff?
No, not yet.
So that might be something to think about before you chase that goose, because, like I think it was said earlier, if it turns out you have certain mutations, there may be other treatments that are more targeted for your specific situation, which to me makes just common sense. It's like, I don't want to be pounding around pegs into square holes. I want to try and find, a square peg for a square hole if I can. And there's a pretty big trend right now for the science to kind of validate that with, certain kinds of gene defects seem to respond to PARP inhibitors, which, by the way, are relatively I'm not going to say they're non-toxic, but the side effect profiles of PARP inhibitors aren't that bad from what I've read.
I would caution you, I would significantly or strongly, I would strongly caution you over that statement, David.
Okay. Well, I'm talking out loud. I haven't had them personally. I don't know. I know I've read that some of the checkpoint inhibitors can be pretty scary, but that compared to that, PARP inhibitors were supposed to be a lot milder.
Well, one of the big issues with PARP inhibitors, and I've now known too many people that have suffered from this, is myelosuppression. They push your blood counts down. And so you finish up with low platelets, low white cells, low red cells. And that can be a big issue. And I've known men with prostate cancer using PARP inhibitors. I can think of 3.
Yeah. Did they bounce back from the side effects?
Only with infusions.
You mean like platelet replacement, that kind of thing?
Platelet replacement and blood infusions, blood transfusions. Professor Bill got 2 units last week and platelets, and that's not the first time he's had to do that. And there are a few people in this country that have probably more experience with taking olaparib for prostate cancer than him.
Yeah.
There are others, and I've known others, and sadly I've known at least 2 people I can think of that were BRCA positive that passed away. Both of them had issues over their blood counts.
After PARP inhibitors.
After PARP inhibitors. Particularly when you're doing it with other treatments.
That reminds me,
in
you're going to put a link to the Gentleman's Club thing in the chat box. Is it gentleman's or gentlemen's?
Gentlemen, I believe.
Gentleman's study. It's gentleman's study. I'll put it in and see if it works. I'm not sure. But gentlemanstudy.com. Try that.
And that's for genetics or genomics or what? I always get this.
It's a study. Well, why don't you let...
Your mic just went dead, Rick.
Why don't you let David tell you, because he's participated in it?
Oh, okay.
Yeah, well, they call it genomics. It is genetics, but they basically they'll do a screen. It's a buccal swab, so they don't even take blood. And I forget how many genes they look for. It's pretty comprehensive. It'll pick up all the BRCA1 and 2 and ATM and a bunch of others, which are the ones that tend to be common in people that have high-risk metastatic prostate cancer, or more common, I should say. So it's not a test of the tumor. It's a test of the cells in your body that, the germ cells, like every cell in your body kind of thing.
And it's a saliva test, did you say?
It is.
Yeah. Okay. So they'll send you a kit and you just mail it back in.
Yeah.
Actually,
get online.
Actually, they send you a color kit and you mail it back to Color. Color is who we have suggested to many people to do their testing with.
Right, that's correct. I think you have to get a doctor to authorize it or something like that. I don't know. I can't remember how that worked out, but is that what you recall, Ed?
Did you? Not with Color. You can go direct to Color, but I don't know about with this study. Did you try it, Jake? Does the link work?
It didn't highlight like a normal link does, so something's missing.
Well, let's put www in first.
Maybe that's what it is.
Gentleman.
There you go. Okay.
Now I think the .com's missing. Well, you try it. You got the idea, right?
Yep.
Okay.
That didn't work either.
It might be a .org or a .gov or something. It might not
is it the Institute of Man?
Guys, listen and try doing a little bit for yourself on this. I'm trying to keep too many balls up. I told you need to put .com after it. Now try it. I'm sorry, I didn't put in the www, then I didn't put in the .com, but I'm trying to run the call and do this all at the same time. So give me some help, guys, please.
No biggie.
There you go. Okay.
Yeah, that's the one. Yep. Thank you.
So, they'll send you the color and they'll send you the color thing and then you'll go from there. Well, I think Jake only asked that question so that we wouldn't have enough time left at the end to ask him to tell us how he's doing. Well, I will give everybody a heads up that he's got something to discuss, because I know and we've talked about it. And it's like getting blood out of a stone, but believe me, we're going to get blood out of this stone.
Sounds intriguing.
Is that my cue?
No, we don't have enough time now. There's only 3 minutes left. If you think I'm going to let you off, and we've got to hang up in 3 minutes, so you don't have to go through it and listen in some detail, you're wrong, Mr. Hannon.
Uh-oh. Just remember, be nice. Okay. We'll get it next time. You know, like you said, I'm not going to see my doctor for 2 months now, hopefully. So plenty of time to talk about it and go into detail.
You're not going to see your doctor for 2 months now. As I said, that's what you think. Okay. Okay. Maybe Len's so curious at this time, he may even call you, and then you won't just be getting it from one person, you'll be getting it from two before you hear anybody else.
Well, I'm going to respect his privacy. When he's ready to talk, he'll talk.
There you go. There you go. I'm disrespecting your privacy because we.
That's right.
Okay.
We missed that. Your mic blanked out again.
I don't know why this mic keeps blanking out. It's showing all the time that it's. I said I don't respect your privacy because we love you, and you're too valuable to us.
Oh, that's the part I missed. Well, I'm glad I made you repeat that then, because that's the part I missed.
I don't know. I heard it very clearly.
You did?
All right. It may not be my mic that's blanking out. It may be other people's connections that fade in and out. That is a possibility, I just want to say.
That is possible.
All right. So we filled up the 2 hours. Anybody got anything absolutely pressing that they want to bring up before we hang up?
Len, I just wanted to say thank you for your good summary from PCRI. I'm looking forward to. You said a lot of stuff, and I didn't understand most of it. I'm going to have to go back and listen to the recording and see the notes that you took when you send them out. And I'll probably have some questions next time, if that's okay.
Sure. And I'd like to thank Rick and Peter for all the work they did at our exhibit table, which enabled me to go to the meetings, the lectures.
Oh, okay.
Ken Mason too.
Right. And I was just going to say, as Peter says, I got to tell you something. If Ken Mason, bless him, had not been there, we would have been in such trouble, because all of the Stefan Fetchit stuff that nobody had time to do, he was so happy to do and take care of. He was just a godsend. I cannot tell you how helpful Ken was. Ken is one of the moderators on Peter's Low call, and he did everything with a really good heart, and he kept us all laughing the whole time we were there. So we were really, really grateful to Ken. One just quick thing I want to say about the DVD. There are probably going to be a lot of people that would like to use this DVD. We cannot make copies of it. We could get into horrible trouble with PCRI, and I think they would pursue us. So we're going to have to come up with some sort of a lending library type of system here. As I mentioned in my letter, these DVDs, by the way, if you want to buy them, cost about $150. So what we're going to do is, I haven't asked Len if he's willing to do it. I hope he will be, but we'll get a list of everybody who would like to see the DVD, and we will ask a donation, at least to cover the cost of postage and handling, and then anything else you feel might be appropriate for having these in your possession for a week, and then we would ask you to return on a timely basis so that the next people can see them. So it may be a while before we get around everybody who wants to see these DVDs. But Len, does that seem like a reasonable system to you?
Absolutely. Anybody can email me and I'll put them on a list. For all I know, it may take a while before I even receive the DVD.
Right.
I don't know how long it takes by the time they produce it, edit it and ship it out.
I was hoping that they would put live links on the, recordings on the internet, but
they don't do that.
They want to make money.
Yeah, they won't do that. No, I mean, last year they even stopped us from live streaming the lecture that I gave. They told us they were very upset to find out that we were going to live stream our lecture, and they stopped us doing it.
Really?
And so we posted it later. We recorded it and we posted it later. So, they make the rules and we got to play by them.
Right, and it's worth remembering that they are a nonprofit organization as well. I mean, they are not, someone just said, making money off the tapes. I think they're going on a donation base. I mean, it's a way to help support PCRI is what's in back of this. That's why they make the tapes available. They're not raking in money by selling tapes. They're trying to support their organization and their endeavors.
Well, I thought they were being. I thought it was sponsored by Janssen and I forget the other company.
They get money that way, just like we did. Yes, they are supported by these, but they're a nonprofit organization dedicated to helping guys with prostate cancer.
Okay, fair enough. I have no objection to that. One other benefit was I got to see Sylvester.
Yeah.
I finally got to put a face to a face to the voice.
Yeah. Yeah.
Thank you. I guess Len sent it to me, so thank you for that, Len.
And yeah, Peter and Len and Ken Mason, you need to Ken Mason's not on, but you need to send me.
Now you went. You and I couldn't hear you.
You went blank again, Rick.
So you need to send me some pictures because Len and Janssen asked me, somebody at Janssen has asked me to forward pictures from the meetings. So any good pictures that we've got, we need to send on to her.
I only have the same pictures that Peter has and Ken has, because it was that picture of us by the man-junk contraption taken by,
Christine.
Okay. Yeah. I don't have any pictures, guys, so please send me some pictures so I can post and I can send them to some people. Okay?
You got it.
Thank you. All right. We're going to sign off now, and I'll see you guys all next Monday. Good night.
Good night. Thank you, everyone. Good night.
Good night, guys.
Good night, everybody.
Good night, everybody. Thanks.